Congratulations, Dr. Wu. So we are calling Dr. Mingguang He to talk about evidence-based myopia control.
Hello, everyone. My name is Ming from Melbourne Unit. Today, first of all, I would like to say thank you to IPOSC and also the Chinese Association of Pediatric Ophthalmology and Strabismus Society invited me to come over to speak in the webinar organized by AAO. Today, I'm going to share with you some of the consideration or thinking on evidence-based myopia control. This is conflict of interest about like a patent and also some shareholding role, and that is relevant to some of the product and solution that we're going to mention in the talk. So I'm going to focusing on prevalence, prediction, prevention, and progression control. So as all we know, myopia is really talking about like axial elongation. So from a normal eye, if you develop myopia, it's got a bit like if you have an axial elongation. If it's extreme or excessive axial elongation, you have high myopia, that will significantly increase the pathological change of the bed of the eye, the fundus. So myopia is prevention is talking about prevent the onset of myopia. And among those developed or with established myopia, we wanted to slow down the progression. This is called control. So prevention and control is equally important for myopia treatment. So a couple of years ago, we already proved that when we use uniform definitions, actually the prevalence of myopia is much higher in urban Chinese children population. So for example, in the junior high graduate, 15 years old, the myopia prevalence can be 80%. And a recent paper published in Japan, can be 90%. So in comparison, comparing to a much lower prevalence in South Africa children, for example, 10% among the junior high graduate. So myopia has become a national strategy or priority for children health or child health, and there's in China. So in many years ago, in 2006, we established a Guangzhou Twin Eye study as a way to understand what's the contribution of genetic factors and environmental factors on the development of myopia. So in this Guangzhou Twin Eye study, we actually enroll a large group of young twins, 7 to 15 years old, and then we managed to annually examine them from 2006 all the way to 2018. So we're talking about 12 years annual visit for these twins. And then what happened, as you can see from this portrait, and then the twins, actually they start when you enroll them, they're 7 years old, very young, and then all the way up to 12 or 10, more than 10 years, they grew up, and then some of them start to wear glasses. And then if you look at these twins and her co-twin, actually they end up with different spherical equivalent of diopters. One is -4 and another one -6. So they're, and equally for axial elongation similar. So they are monozygotic, they're genetically the same, but then they end up with different myopia outcome. So then, but if you look at the distribution in the monozygotic twins and dizygotic twins, actually the monozygotic twins show much greater correlation. That's suggesting a very strong genetic effect. So when we look at the baseline, I mean the longitudinal change of the spherical equivalent among these twins, actually what we observe is that from time to time, and then from baseline to 8 years follow-up, actually the mean of the spherical equivalent switch to myopic, like a myopia shift, and then the variation significantly increased. And then from the heritability analysis, we kind of proved that if someone got -10, another one got -0.5, among this variation, a lot of this variation can be actually explained by genetic background. So, and also the twins give us opportunity to really observe what happened before and after the onset. So this is a paper we published a couple of years ago, and then we proved that actually before the onset, there's an acceleration in terms of spherical equivalent changes. So they got much greater change. All of a sudden, it happened like we talk about from -2 to -9. So this is like to -8. So this is in 1 year time. This change can be as great as 0.8 or 0.7 diopters per year. So big changes before the onset of myopia. And then after that, after the onset of myopia, the changes over time reduce. So this is a very interesting phenomenon. And then in clinical practice, we understand that if some children 7 years old -2 diopters and a 12 years old -2 diopters, we understand this the younger one, the early onset one, got a much higher risk of developing high myopia in adulthood. So, but then if we put this into the context of, like, we call it percentile curve, that is more easier to understand the risk. For example, 7 years old -2, this is really below the 3 percentile. So this the chance of being normal is just less than 3%. So this with this percentile curve, we can easily differentiate or tell what's the risk of the for the children to be abnormal in the population norm. And then similarly in the twin cohort, we kind of proved that with this long-term longitudinal study data, we proved that if someone got age, like onset of myopia 7 or 8 years old, so the chance of having myopia when they reach 18 years old is, like we talk about, greater than 50%. But then if someone got myopia onset very late, and 13 years old, so the chance of having myopia in adulthood, like 18 years old, so it's all very low, it's 3% only. So similarly, we can also predict what is the diopters, the medium and variation of the diopters. For example, for someone with age early onset, 7 or 8 years old, early onset myopia. So in 18 years old, the mean of the or medium of the diopters would be -6. But then for someone with very late onset of myopia, like 15 years old, and then it will end up like only -2. Most of them are just -2, and for 18 years old. So then we also further proved that actually the baseline or age-specific spherical equivalence is very important predictor for predicting who will develop high myopia in 18 years old. And then also the genetic data, like the genetic genome-wide association, like SNP data, is not that helpful as long as we have the age-specific spherical equivalent data. So then also in China, we run a long-term, like about 10 years high myopia registry study. Every 1 other year, we examine them, about 900 high myopia patient. And then we proved that actually the MRI scan on the eye shape or ocular shape is a good predictor, very important predictor for development of pathology changes like diffuse atrophy or even like atrophy and other changes. And then we further proved that the choroidal thickness under the macula actually is a much better predictor than the spherical equivalent. So this is the best predictor, is actually is a subfoveal choroidal thickness. The ROC got a much better on this single predictor. And then I'm going to, there's so many risk factors that have been identified. Education is important. And then there's Professor Xuehan may prove that reading, the number of reading and the intensity of reading is important predictor. But then also parental myopia surrogate for genetic background, or can be a mild genetic environment. So if you got myopic parents, so you got much higher risk of developing myopia. So unfortunately, we can't change our genetic background. And then in a lot of social cultures, we are not able to change our reading behavior as well. So then outdoor become very important. So this is the Sydney myopia study. In Guangzhou, we proved that in randomized control trial, actually every day 40 minutes additional outdoor time is going to prevent about 20% of the onset of myopia, very effective. And then we further try to translate this like an outdoor exposure, light exposure, to really localized or local retinal exposure to light as a treatment, as an alternative treatment. So this is randomized control trial, the red light therapy. And then this is home use device. Just the parents, the children need to bring home and then just run or implement these treatments 3 minutes per section, two sessions a day under the supervision of the parents. And then this light therapy actually demonstrate a very strong prophylactic or a very strong efficacy in terms of controlling axial elongation, 70%, and 76% or 80% efficacy in controlling SER, spherical equivalent progression. When the compliance is good, like 75%, so the control on the spherical equivalent can be 90% control on the spherical equivalent progression, and then there's not much side effect demonstrated. And then we also see choroidal thickening, and then also interestingly, we observe significant axial shortening. Like we talk about reverse of myopia at a certain degree, and then the possible mechanism may be associated with scleral hypoxia. And then the take-home message is myopia should consider both onset and progression. Predictions enable us to identify who need more aggressive treatment. And then outdoor is effective for prevention. And then there's optical pharmaceutical treatments for myopia control. And then this repeated red light therapy can be an alternative. Thank you so much.
Very nice talk and very nice papers. Thank you very much, Dr. He, for your wonderful lecture. So again, we are going to discuss at the end of this session.